Katie Ohlert, a pharmacy manager at a small chain pharmacy, recently took a class on smoking cessation. She enjoys using her new skills to help people quit smoking, but wishes she could bill for her time and provide varenicline, or Chantix, to her patients. Checking her email one morning, she sees a message from the State Pharmacy Association informing her about a bill, H.R. 321, being considered in the state legislature that would designate pharmacists as healthcare providers and allow them to, among other things, furnish prescription smoking cessation aids to patients without the need of a prescription. Katie knows this would make a big difference in her ability to provide care for patients and really wants to have these privileges. She doesn't know, though, how to advocate for this bill, and the idea of getting involved in politics makes her uncomfortable. She also doesn't understand why the state has the power to make this change, but hopes H.R. 321 can force Medicare to pay for her beneficial smoking cessation services. She wants to know more about the health policy making process and the healthcare system so she can eventually advocate for provider status in her state and expand her ability to serve patients.
In order for Ms. Ohlert to get more involved in health policy, she needs to better understand how it works first. The first step in health policy involves the legislative branch, which is made up of the Senate and House of Representatives. Any constituent can contact and work with their elected federal or state legislators to get a bill introduced. Generally, pharmacy associations take part in this step, but individual pharmacists could also take part. Once the bill gets introduced into legislation, pharmacists then can urge their legislators to vote on the bill. To help encourage the support behind the piece of legislation, pharmacists can support lobbying efforts of pharmacy associations such as their political action committees, known as PACs. If the bill passes both sides of the legislative branch, it is then given to the executive branch to be signed into law and implemented. At this point, laws are given to the government agencies to be implemented, such as the Federal Department of Health and Human Services, known as HHS, or a State Department of Regulation and Licensing. These agencies work by proposing rules in order to be put into effect. With all federal agencies, proposed rules are published in the Federal Register, followed by a period where comments can be submitted by constituents about the proposed rules. After taking these comments into consideration, the agency publishes final rules to implement the law. The third branch of government, the judicial branch, can be involved in health policy as well, because they often hear cases that involve interpretation of the law. In the past, pharmacists and pharmacy associations have sued in order to stop the implementation of a specific law. Ms. Ohlert can get more involved by being a part of pharmacy organizations and attending meetings because they are a key resource for information about health policy issues pertaining to pharmacy. One of the best and easiest ways to be involved is to write a letter to the state legislators stating your views on pharmacy policy. Lastly, pharmacists can use websites such as congress.gov to learn about pending and past federal legislation.
Pharmacy organizations are a key resource for information about health policy issues of interest to the pharmacy profession. Almost all pharmacy associations' websites maintain a government affairs or advocacy section where viewers can find information about current health policy issues. More conveniently, most pharmacy associations have websites allowing members to sign up to receive legislative updates via email. All of these different resources would be beneficial for Katie to look into. Medicare is a federal government health insurance program that covers health care services for individuals 65 years and older, disabled individuals, and individuals with end-stage renal disease. Medicare policy falls entirely under the scope of the federal government. Originally, Medicare consisted of Part A that covered hospital costs and Part B that covered outpatient costs. Now, however, Part C was implemented to provide Medicare beneficiaries the option to sign up for private health plans known as Medicare Advantage plans. If the beneficiary chooses a private plan instead of the original Medicare, the government pays for a portion of the premium for Medicare Advantage plan, and the Medicare Advantage plan pays providers for care. Under Medicare Advantage, the government is a purchaser of insurance rather than directly being the insurer. Overall, individuals may sign up for the original Medicare Parts A and B with or without Medicare supplemental insurance, also known as Medigap, through a private insurer, or they may sign up for Medicare Advantage. Both options also offer Part D drug coverage for Medicare Parts A and B with or without Medicare supplemental insurance, also known as Medigap, through a private insurer, offers it through private Medicare prescription drug plan, and Medicare Advantage offers it through a Medicare Advantage drug plan.
Describe Medicare Part D and discuss its effects on pharmacies. Medicare Part D is a voluntary prescription drug coverage that is available to anyone who is enrolled in Medicare plans A or B. It affects pharmacies by sponsoring MTM services for selected beneficiaries. Pharmacies are able to lobby for changes in these programs to their state legislator and push for change and reform. Medicare Part D has many different plans, and with each different formularies, reimbursements, and benefit designs. This can be very confusing to pharmacy staff and take away time from patients. Describe the Medicaid program and understand the dual role of states and federal law. The Medicaid program is a health insurance program for low-income individuals. This is funded and run by both state and federal governments. Programs can vary between states in terms of provider reimbursement, covered populations, and covered services. Unfortunately, the number of people in need of Medicaid increases while state budgets decrease. Federal funding varies between states based on the amount of Medicaid-eligible individuals. The federal government also determines a basic set of services, including in- and outpatient hospital services, physician services, laboratory services, and long-term care services. Prescription drugs are currently an optional service to be decided by each state. Currently, all states are covering this.
The Affordable Care Act was a reform passed in 2010 that expands health insurance coverage, provides additional protections for patients, controls costs, and improves healthcare delivery systems. The Affordable Care Act, or ACA, has decreased the number of people who lack health insurance by 1, providing incentives for people to purchase health insurance, and 2, reduce barriers to the purchase of health insurance. Incentives include imposing a mandate that requires most individuals to have insurance, or they will be required to pay a penalty, thus encouraging patients to purchase coverage. The ACA has created health insurance exchanges, or marketplaces, that help individuals and small businesses shop for private health insurance coverage. Each state may operate its own exchange. Subsidies or tax credits are available to individuals and families with income within designated federal poverty lines. The plans must cover essential health benefits to some degree. For private health insurance companies, the ACA requires guaranteed issue, meaning the insurer must agree to insure patients regardless of health status, and also requires guaranteed renewability, meaning once a policy is sold, the insurer must continue to sell the policy to the insured regardless of changes in their health status. For Medicaid, the ACA promotes expansion. For Medicare, the ACA is phasing out the coverage gap and has increased Part D premiums. There are also changes that businesses must take note of, requiring employers to offer health insurance and also introducing an excise tax on expensive employer health plans. As a pharmacist, the ACA presents challenges and opportunities. By increasing the percentage of people insured, there will be an increase in the number of prescriptions dispensed. As Medicaid expands, the net effects on pharmacies will depend on reimbursement levels set by the state programs. Effects on pharmacies also depend on MTM services payments. There are also presented incentives to get involved with integrated care organizations, which include collaboration. For our case, Katie Ohlert is looking to get her pharmacy involved in smoking cessation programs. The success and profit of this plan will be dependent on her state's Medicaid programs, the opportunities and incentives provided for MTM and collaboration, and reimbursement formulas.
In the beginning of the chapter, our pharmacist Katie Ohlert hopes in vain that the state bill can mandate payment through Medicare for smoking cessation services. Unfortunately, states do not have this authority. Instead, the bill described interstate would designate pharmacists as providers and expand privileges to provide non-OTC smoking cessation aids without a prescription, but would likely do nothing to secure payments for services. Of the 3 policy goals, payments for services is the most difficult to achieve. It is difficult but not impossible to successfully lobby for policies requiring specific healthcare services to be covered for payment. Autism treatment and chiropractic care are examples of services that some states require health insurance plans to cover. Most of this legislation has been at the state level, but some federal mandates also exist. Pharmacists and pharmacy associations have lobbied to mandate pharmacists as a covered provider or pharmacist clinical services as covered benefits on both state and federal levels. Sometimes benefits are mandated for a specific population, and sometimes they are mandated for all insurance plans. The exception is that state benefit mandates are not be imposed on self-funded plans. These plans are regulated at the federal level. At the federal level, pharmacists have lobbied for legislation to expand payment for MTM services. Benefit mandates are generally opposed by the insurance industry. In addition, when pharmacists lobby for a policy to expand coverage for patient care services, other healthcare provider organizations may be in opposition. It is hoped that securing payments through Medicare Part B will lead to broader adoption of payment policies for private insurance. The pursuit of provider status, as with any complex policy agenda, will take years and potentially decades to produce meaningful change for pharmacy. It is imperative that pharmacists, like our pharmacist Katie, join pharmacy organizations in advocating for policies that advance the profession. Although specific bills introduced at the federal or state levels are not discussed here due to their fast-changing nature, it is important to recognize general categories of legislation that are likely to continue to be important in the future. One type of legislation is regulation of PBMs. Health insurance companies have historically been heavily regulated by states, which PBMs have minimal regulation. There has been legislation passed in some states to regulate PBMs. It is likely that additional legislation related to PBMs will be introduced at the state or federal level in the future. Pharmacy associations have also supported efforts to limit restricted pharmacy networks, limit the use of incentives or mandates to use mail-order pharmacies, and regulate third party reimbursement. Finally, there's a broader range of health policy issues where pharmacists and pharmacy associations may choose to get involved. Examples include reimportation of prescription drugs from other countries, controlled substances policies, electronic medical records, drug shortages, counterfeit drugs, generic substitution, medication disposal, competitive bidding for DME, and pharmacy compounding. Pharmacy organizations representing specific pharmacy groups will concentrate on issues that are of interest to their members. However, in recent years, they have tried to present a united front on many issues that are of critical importance across all areas of pharmacy.